Welcome everybody. If I could introduce myself, my name's Alex Leach. I'm the Deputy Director of Programmes with Health Innovation West of England. I have the privileged position to head up the work that we do working with innovators, and I largely deliver the work we do under the Office of Life Sciences Commission. This is the first of 3 panels that we're running today, and we're really aiming to look at the way that we can improve collaboration between healthcare, the universities, the other wider ecosystem and industry. How can we support that journey that Hassan really clearly described as being quite tricky and difficult? I've got 3 great panelists to join me, and I will get them to introduce themselves shortly. We do also have we have some questions that I'm going to ask them straight away. But I would love to get some questions from the audience as well. There will be 2 ways to do that. One of them is utilising Slido again. We do love our Slido. So feel free. One of my trusty team is manning an iPad. Or actually it's a phone. And we will certainly, if you feel that you would prefer to ask your questions through Slido, please do. You can upvote questions on Slido as well. Or you can put your hand up at the end and we'll obviously take questions from the audience. So if I now pass to the rest of the panel and ask them to introduce themselves. Let's start with you.
Hello everyone, I'm Febin, I'm the GP in Swinton and I'm still practicing, and I'm also a clinical lead at the Health Innovation West of England.
Hi, I'm Gompertz. I'm a former NHS doctor for 30 years. The last 20, one of those is a GP. I'm now CEO and founder of EarSwitch for the last 3 years. We started off unlocking communication for people with motor neuron disease from an earbud, but moving on to do all your medical monitoring from your ear at hopefully high grade and racially unbiased.
Hi everyone, my name is Stephanie J and I look after enterprise and innovation activity at the enterprise zone here at UWE. I work particularly in launch space to support early stage founders and startups on their entrepreneurial journey.
Thank you so much. So what I think you'll see is we've got a really nice mix of people who are working at the front line of healthcare. We've got somebody who was a clinician who's now become an innovator, so sees things from both that angle. And we've also got Stephanie's expertise working with spin-outs, new industry, and really trying to support those companies that are quite early in their stage of development to be able to work more closely with healthcare systems. So the first question I'd really like to ask, Nick, as an ex-clinician or a current clinician, an early-stage innovator, what is your experience of the opportunities to collaborate with clinical colleagues and other support organisations to support your innovation to date?
I mean, I've been very lucky, in that because I have a natural sort of links into clinicians because of where I've come from. So, you know, I've got colleagues who've been in any of the specialties. So I'm also very lucky in that what we're doing is actually very well supported by people just generally. So racial equitable oximetry, better quality care, and also unlocking people with motor neuron disease. So I'm very lucky that there's a sort of real tie-in to what people do. So to work with clinicians has been generally very easy. There are organisations within the ecosystem that have been less easy to engage. I must say West of England AHSN or Health Improvement Network has been fantastic. They weren't the first contact I had with AHSNs which hadn't been so successful. So I think you have to choose who you go to. And I think there's also quite a difficult understanding necessarily of what can be helpful, certainly for a jobbing clinician, you know, obliging a jobbing clinician to come to a full week's or a certain number of sessions full time, or when they've actually got a clinical role, there has to be some flexibility. So it's been variable.
Okay, perfect. And Febin, you know, obviously GP practices, hospitals are really busy places. The focus of any clinical area has to be on delivery of high quality care. What do you think the role is of hospitals and the clinicians within it to really support early stage innovators in honing and developing their technologies?
I think we've got a remarkable role in shaping those innovations to make them understand the potential of their ideas, help them navigate through the nuances of the health and care system, and also giving them the headspace to carry out those innovations, to think about their ideas and make it market ready. Like Hassan said, your idea might be brilliant. You might have a brilliant product and you think, wow, we are going to change the world. But if the market isn't ready, it's not going to succeed at all. And also, you should be a bit more adaptable to adapt and change according to the market. That's one of the things I find with the clinicians often. They've got these brilliant ideas, but they never get the platforms to understand the market readiness of their ideas and how to spread it across the market. And I think Health Innovation West of England, our Healthier Innovate Together fellowship program, those are the platforms that give them that extra credibility to test that market or at least understand the market. And we need to send this across to the clinicians all across, not just the clinicians, it could be anybody in the healthcare system, but often they do not understand the end-to-end visibility of their ideas. I think it's really important for people like us to help the clinicians to come up in that space and also give them the headspace to carry out those ideas.
Absolutely. Perfect. And Stephanie, I mean, obviously universities are often seen as places for education, for research. What do you think is the role for universities to really help innovators in the wider healthcare system drive healthcare innovation development?
I think universities play a pivotal role in supporting startups beyond research. And I'm going to do a quick shameful plug in here, because we talk about this a lot on our podcast, our enterprise podcast, Innovate Together. Make sure you listen to that on any podcasting platform that you use. Or we often describe the university as a innovation hub. And there's so many benefits to startups for partnering with universities. One, the fact that it can offer a certain level of credibility to your startup, but also it provides access to valuable resources, and that could be, cutting-edge facilities for research. It could be expertise of the researchers. At a university like UWE, we have incubation zones like launch space and future space that then offer things like business mentorship, advice, technical expertise to the companies. And what that does for them is it opens them up to an ecosystem where they can learn from other people doing what they're doing. But also the university is a great place to find really early stage talent that they can recruit, students who are looking for internships, and I imagine that the universities usually pay for that. So they get to work with really talented individuals to help build their product for free. The only thing that I will say is while the universities are quite great to support for supporting startups, they tend to have a traditional academic timeline, which is very different from the timelines of startups. They need quicker timelines. So I think it's about the startups understanding and identifying clear and objectives that they need in that partnership with the university, and just recognizing those two timelines and not being bogged down into the university's traditional academic timelines that could be slower. But I think the university is particularly very, very useful for that support system.
Nick, I know you did quite a lot of work in your early days working with the universities. What's your sort of experience of that?
I would either still be a GP or be retired by this stage. So universities were the only way I took this forward. I had reached out to various different organisations that I thought had a remit to help innovators that didn't help. And it was only a fortuitous meeting through the University of Bath, actually Entrepreneur in Residence through the Set Squared programme, that I got my first traction, which was basically an exercise physiologist who was interested in working with us to provide this motor neuron disease switch. And with them, we actually, with Set Squared funding for a bid writer, we actually got our first NIHR iFly Connect grant. So we were lucky we got the first grant that we applied for. And that then led to about 6 grants within about 18 months. A lot of them around the University of Bath, but also with Heriot-Watt University and more recently UWE. So we've done 2 UKRI funded grants with UWE. So I always say to people, I'm on the NHS Clinical Entrepreneurs Programme as well, and I say to my colleagues there, is seek out your local university or any national university. You need the one that's interested in what you're doing sometimes. Sometimes it's just your local one. And actually without that, I wouldn't be here. So university and the Future Space Launch Space, Mark's here from that, was fantastic. And each one so I've been on multiple accelerators, and each one of them gives you something different. And each university actually gives you an academic that has specific interest in what you're doing. So I've been talking to Manchester University, and their audiology department's very interested in what we're doing. So I think the more you speak to them, the more you're likely to get a very enthusiastic person who will run with you.
No, that's great. Sort of question for you, Feb, and maybe it's a little controversial, but do you think that the NHS is too risk adverse to truly innovate?
I would say probably traditionally, yes, we were too risk averse, but I think the landscape is rapidly changing. And one of the reasons for the change is because of what's happening around us. And when we say about innovation, it doesn't have to be a product, it doesn't have to be years and years of research. Very simple ideas, even about the working patterns, they are innovations as well. So anything that could change for the betterment of patient care or even the staff care, that is an innovation. So it doesn't actually have to be a product. Now the reason for the risk averseness, I think, is because of how it was, innovations were traditionally viewed as, oh, that's a change. It's something different from what you used to do. And what's the research methodology behind it and who has approved it. I think those were the reasons where people were very risk averse. But it's rapidly changing. And I think organizations like us has also contributed to that bigger change. And I think it should also come from each one of us. Don't be afraid to voice out what you really feel about something. If it doesn't work, just say it doesn't work, and not in your WhatsApp group, like Sam said. Be courageous enough to say why it didn't work. Because as a practicing GP, I often get the end-to-end visibility of some of the innovations or some of the things that we do on a day-to-day basis. And most of us knows it doesn't work, but we don't want to say it. And I would say that be courageous enough to say why it doesn't work and what is the solution for it. Because we often know what the solution is, but we're worried about, oh, am I saying the right thing? Would I upset somebody? But I think it's the language that we use as well. Rather than a deficit-based language, we need to adopt an asset-based. Look, these are the things we could do. These are the things we could change. And I have tried this. Why don't you try this? And talk among yourselves. Talk among your peers, your colleagues, to the next department, to somebody else from the university, and somebody else might have thought the same. And that's how ideas come out.
I think that's really interesting, Febin. And I look back, I originally was a nurse. I largely saw reps as being a route to pens and post-it notes, I'll be honest. But then when I moved into industry, and I worked in industry for quite a long time, actually I really valued those clinicians that took the time, even if my product that I was trying to sell them wasn't right, who took the time to explain to me what they needed, why it wasn't right, help me to learn. And certainly when I worked for startups, that one conversation where someone gave you that time was the pivot that you needed to help you to suddenly go, oh, actually, I'm thinking this wrong. So please, a call to all the clinicians in the room, share that valuable knowledge with industry because you will make a huge difference. So Nick, your experience was inspired by your work as a GP and some of your experiences that you had clinically. Do you think it's actually possible to innovate from the front line of the NHS?
I'm quite passionate in that we should be doing grassroots innovation. As part of the NHS Clinical Entrepreneurs, actually a lot of those innovators are coming out of the NHS and selling back in. We shouldn't need to have to do that. Now, it's a good step, and it's a really, Prof. Tony Young set up a very good system there, but they're beginning to actually expand into entrepreneurship. I was saying to someone earlier that my wife should be here because she's an NHS clinical entrepreneur as an entrepreneur on that programme. So she's making service change. And so I think the NHS is full of people who know the pain points and full of people who've actually negotiated those pain points and done those innovations locally. But quite often that innovation does not expand beyond even between one surgery to another or one ward to another, not even from one office to another, because people don't actually have time to actually scale out to your colleagues, or they're not willing to. So my plea has been for some time is that we need innovation scouts within the NHS who actually go into every single practice and every single environment and say, who is your innovator? Because we all know who the disruptive person was. You know, that was me. So you go to that disruptive person and say, what have you seen? How have you managed to do it yourself? How can we? And then actually become the co-founders. It doesn't need to be commercial, but co-founders in the way that co-founder is normally someone who augments and actually provides that person with time and energy and resources to actually expand that outwards. Now, I've seen my wife struggle. I didn't manage to do it in the NHS, I failed. My wife has managed to do it and struggled to do it, but is doing it. And it always needs that person who's just committed to what they're doing. In other words, they're just passionate. They go the extra mile. We shouldn't make it difficult. We should make it easy. So I think, you know, there's a great scope to take some really amazing changes and take them from the bottom up, not top down. I think it's too much top down and it just doesn't work because people don't know the pain points or how to adjust them. That's my hobby horse, so I'll get off it.
No, great points. So Stephanie, how do you feel we can support clinicians to contribute to and advocate for new technologies being developed, both within places like universities or from start-up or SMEs?
I think we have a really key role to play. I say we being the university, in the sense that we need to create accessible pathways to allow the clinicians engage with the startups at that really early stage. Clinicians are busy. They often don't have enough time. They have a lot of pressure and a lot of work that they have to get through. And so it's understandable that they don't want to commit heavily to anything that will add to their time. So it's really important that we create low entry points for them to engage with those startups. And particularly at UWE, one example of the way that we do it is at we have a health tech hub at the Enterprise Zone. And what that does is it bridges the gap between the startups, the clinicians and their organizations, as well as the university. So essentially, it provides opportunities and encourages clinicians to engage with those startups really early on. That could be maybe having some of those clinicians on the advisory boards of those startups, or having them get involved with early testing to receive feedback. Because what that does is it helps the startups produce products that are not only practical, but that can be very transformative to patient care. So I think it's quite important that we set that up and create those pathways to allow that integration.
No, that's great. So, sort of based on all of that and those wonderful resources that the university are providing and the accelerators, Nick, you've also mentioned an awful lot of support you've had from the wider ecosystem. How can we better broadcast that ecosystem to clinicians, to startups, to intra and entrepreneurs, to help them realise what's out there? I mean, I've certainly heard from quite a few that they didn't, even though we've been going as a health innovation network for 11 years, I regularly hear about people who say, never heard of you, which is really sad. But it's true. So how can we do it better?
Yeah, interesting. I think when I was a GP, I was in a GP in a very rural, I was in Somerset, and actually we were a long way away from here, to be honest. And so I think Somerset's actually a poor cousin, so I don't actually know what happens here. But I was thinking, locally, to actually have clinicians coming in, there's a lot of, people talk about NHS being resistant to change. I don't think clinicians are, and I'm talking about clinicians across the board because they know there needs to be change. It's the system that puts the brakes in. So I think to get it out there and actually get some clinicians coming to, I mean, I would have done it, you know, so an excuse to get out of the practice and come and see some innovative companies. A lot of my colleagues actually don't know there's actually an innovation ecosystem. I didn't know that there was a whole innovation ecosystem out there. I sat in the same desk for 21 years. I thought I had no transferable skills because I was doing the same as my colleagues. And actually, you come out of this and suddenly you realise you do. So I think it's really getting it out. Yeah, and they are very busy. I mean, I have all my hats off to anyone who's still a GP. It's phenomenally difficult to have any time to do anything else. It's almost having a 10-minute appointment with the innovative GP in each practice coming from the GP side, from HIN to say, can we speak to you? And literally fit into their timetable. And so instead of a patient, they get a 10-minute appointment to talk to you. They love it because it'll be a break. And actually just get that out there. And I think it's opening up. So the other organisations, National Institute for Health and Care Research, we've had 3 grants from them. Fantastic. They've got lots of, they've changed the names now. I can't remember what they call their various different outreaches now, but they're very useful. UKRI funding, again, but these are all very competitive. And when you start, you've got no bandwidth to do anything. I think it's just having those conversations, and I think you'll find that a lot of people would want to make changes and want to help.
And I think in a bit of a shameless pitch for the Health Innovation Network, it's very much our role to connect. So if any clinicians or innovators really are keen to learn about the ecosystem, please reach out to us, because that's why we're here. So Stephanie, the most powerful innovations often come from times when the innovation is developed as a direct result of a need that's been expressed by the system. How can we help innovators identify genuine needs?
Interesting question, and we've talked about this a lot, haven't we, Mark? We have 3 principles at LaunchBase that we encourage a lot of our startups to make sure that they figure out in order to increase their chances of success. And the number 1 is, understanding and identifying a problem, a meaningful problem. Second one is developing a valuable solution to that problem. And the third one is identifying a market. And number 1 speaks particularly to this question, because most times it seems that startups tend to develop products that respond to a perceived problem as opposed to an actual problem. And it's really important for startups to develop solutions to problems that people actually care about. Because if the solution is meaningful, if the problem is meaningful enough, if it's big enough, if it's dire enough, then users are more likely to try an imperfect solution. We talk about at LaunchBase, we often use the Y Combinator analogy of your hair and fire. If you're standing next to someone and their hair is on fire, a friend, at that point in time, the only thing they care about is the fact that they need to put the fire out. It doesn't care if they've just had a breakup text. It doesn't care if they've just lost $1 million. The only thing they care about at that point in time is getting the fire out of their hair. So if you give them a perfect solution, which is a hose, they'll be able to use it, and cool, problem solved. But if you give them a brick, they'll still try to use it. I mean, the brick is not ideal, but it's an imperfect solution at that point. And Y Combinator explains that in a way that makes you understand that if the problem is big enough, if the need is big enough, then people will be more willing to try an imperfect solution. So again, we encourage startups to be able to rapidly iterate, using MVPs, put it out, test it with the customers, use that feedback, take the learnings and integrate it into the next one. But like I said, if the customers aren't even willing to try the imperfect solution because the problem is not necessary, then you're gonna have some issues there. So we often encourage startups to find a problem that's really meaningful.
Nick, did you want to add to that?
Can I add just, I find there's a conflict between NHS and commercial, because good value does not necessarily mean it's commercialised. So where I started was, there's not criticising what you're saying, it's just looking at the differences. So I started off doing a switch for people with motor neuron disease. It's a tiny market, it's not a commercial market, it's a massive need. And I think in the NHS, there's a danger that we've gone so that everything has to be price-based, cost-based. We need to look at social and individual value. And once we go back to the person, that's where we see the value. It shouldn't all be about cost, and I know it is. So I think at the moment, obviously, we're a commercial company. So the metrics has to be commercial. Our EarSwitch for communication is never going to be commercial, but it has to happen. And so, there's always a role for those commercial ones, but there's also a role for the non-commercial ones as well. So.
No, that's brilliant. So, Febin, how can we facilitate co-design? How can we get clinicians, innovators, universities to work together to really solve some of those tricky, real problems that Stephanie just described?
One thing we need to remember is most of the these innovations or products that we develop, we are not the end users. The end users are the patients. So every single, like Stephanie said, problem-based. If you have an acute problem, you really want to solve it. When it's somebody else's problem and when it's a commercial thing, I don't think the effect would be the same. So I think we need to get the patients involved from the very beginning because they are the end users. Any kind of product that we develop, I think there should be a question, what is the patient involvement here? How many of these patient cohorts has been involved in developing this product? What kind of voice they had in shaping this innovation? Only then it becomes meaningful. And that's part of market readiness as well. And if you are looking at 1 in a million people going to use that particular product, it might be brilliant. That is going to be not that widely adapted and spread. But if somebody says probably 1 in 100 people might use it, that's market readiness as well. So that patient involvement and that patient voice is quite key. And I think people like us, when any kind of ideas comes to the table, that needs to be part of the pathway. How has this been co-designed and co-produced with the end users? It could be patients, it could be staff, it could be anybody, but the person who's going to use it, how many of them has been involved? And some of the things I hear from the innovators is, but where do we find these patients from? And again, that's an interesting question. You can't just go down the street and ask, oh, can you try this? So what kind of platforms are there to recruit these kind of patients who might be interested in testing or even voicing or shaping that particular product? So I was talking to some of my patients on Monday about some of the innovators here, and I thought they would, it would be useful for them to hear about these innovators and how it would change their life. And they said to me, oh, Dr. Basheer, who are these people? I've never heard about it. I would like to try it. How will I get one of those? At least I would like to read it. Then I thought everybody knew about these innovators. Not really. The person who's going to use this has never ever heard about it. So I think co-designing and co-producing, the patient involvement is the key thing. Like Nick said, there are a lot of platforms these days for the clinicians, for the innovators, probably from other healthcare organizations that would fund them. But the lack of patient involvement and meaningful involvement, not just a tick box exercise to say, oh, we have spoken to these people. No. And also to provide those platforms where we can actively get those patients involved. That's when the co-designing would be successful. And facilitating it, I think it's part of each and everybody's job role. And like Nick said, when you're a practicing clinician or if you have other jobs, it's quite difficult to have the headspace or even find the time even to have that 2-minute conversation about, there's something else out there coming. Would you like to try it? And how do we incorporate that into everybody's job plans? Not as a full day session, but probably part of a motivational talk, motivational interviewing, which comes as part of the daily conversations. I think that's where we need to make the change.
Yeah. Completely agree with everything you've said, but I think it's important to also just mention that co-design should not limit your ability to iterate. Again, startups don't have the time to waste, especially in the world that we live in right now where AI is pervasive and solutions are being formed rapidly. You want to test early, fail fast, take the learnings, and use that to iterate the next increment of your product. And I think co-designing with the patients or the clinicians, depending on the case and the type of startup, really important. But the startups need to also remember that they need to be rapid and they need to be putting out a valuable product. You want to get a valuable product to market as quickly as possible. So I just wanted to add that to that.
No, that's such a great point. So one final question for each of you before we pass over to the audience. What do you see as the biggest barrier to early collaboration between healthcare providers and innovators, and how do you think we can work to overcome it? I'll start with you, Nick.
I think if it's innovators coming from outside the clinical pathways and who don't understand them, it's actually coming with the wrong question or the wrong solution. or one that doesn't fit in the work the work process. You know, if you say to a GP that we've got this amazing thing, you'll get a diagnosis of UTI within 5 minutes, and that's, you know, half of their consultation gone. It won't work. So things have to fit in within the pathway. So you can have amazing innovations, and so I think it's actually talking to those people who know where the pain points are and now know how it works. There is a slight problem with that, is that if you're completely changing the paradigm, you might have to sell that paradigm to them as well, but you have to know where it will fit. So it's a real difficult one.
Perfect. Stephanie?
Just to add to that, I think the pace of innovation and the operational realities of the healthcare system, which tend to be more risk averse and process driven, is a real big challenge there. And in terms of managing that, I think it's just important to remember to start small as a startup. You know, you don't have to have extensive, you know, testing or research periods. You can just have a pilot program that you can get, you know, the clinicians or the organizations involved in, you know, without any major disruptions. They're more likely to be open to adopting that new technology. I think it's also really important to have clinical champions, so people or organizations that are keen to be early adopters of technology, and they will advocate for your product, and they will help you navigate those institutional barriers that might arise. But also the most important thing is being able to consistently deliver incremental value in your product, being able to demonstrate clearly the benefits of your product, and using that to build an evidence base that can align with the priorities of the healthcare system. I think that could really help.
Well, that's great. And finally, Febin.
I would echo what Nick and Stephanie said. For me, it's the pace of change that is really, really slow. Most of it is like the Heathrow runway project, which has been going on for years and years. And by then, there are other airports that has come up all across. So it's the same in healthcare as well. That pace of change that needs to be rapid, and also allowing the innovators to test and understand the market pretty quickly, and also helping them to navigate the nuances of the health and care system. People don't know where to go, how to go, and I think that needs to be in from the very beginning of their training, to say that as part of their induction into a university course, if you have a good idea, this is where you go to, and make it as a part of the curriculum so people understand where to go to and how to develop those ideas. I would say those are the two biggest barriers. And also, one of the other barriers is that the ICBs or the healthcare systems, how many of those has got innovation in the yearly planning cycle? And also, yearly, many of the ideas, it takes at least a couple of years to have an evaluation. So I think it should be at least a 5-year. And we need to evaluate not the ones that has been really successful, but if we had failed on something, why, and learn from it, and to see what we can do to make it better, because the idea might have been better, really good, but somewhere along the pathway it did fail. And to understand that, I think we should give equal importance to both, not just the successful projects.
That's wonderful. Thank you, everybody. So I think now's the time to pass it over to any questions. By all means, if you want to put your hand up, if you've got a question, be very happy to take them. I think we've also got, have we got some on Slido as well? So,
I just want to say to Nick, a disruptor is quite a negative language. Agitator, I've been called. I'm very happy with that title. And I think using that rather than disruptor, and I definitely think all of the clinicians here are agitators to be able to change things.
I like being a disruptor. And I think for all those people who manage organisations where you have a disruptor, are they actually a disruptor, or are they the people you should really be going to for your new ideas? I think they're probably the latter. There will be some who are disruptors.
Okay, I'm going to go to Slido. So one of the most popular questions was, how do you replicate innovation across trusts or primary care or wherever that may be without repeating pilots?
Who'd like to answer that one?
Just an easy question to start with.
I'm not a big fan of pilots, but often why the pilots come up is because of the lack of adequate resources. It could be resources in terms of funding, manpower, but that's where the pilots come from. And our ecosystem needs to be a bit more adaptive and be really courageous to say, let's do this across the system for a certain period of time and see what happens, but not stop it, because often the funding is very time limited and we never get the time to evaluate an outcome and build on it. So it has to be an incremental one, saying that we'll do it for 2 years, we'll have an evaluation while it's running for 2 to 3 months, and then learn from the points and change it. I think the biggest problem is the funding. And I think if we can nail it, I know that's a big problem. I know many people are working on it, including West Reading, and hopefully if we can get that right, that will be a major change.
Completely agree, and I'm just going to add to that. I think the main thing there is being open-minded and just being able to shift perspectives, really. Innovation happens in a lot of ways. It could be pilots, it could be engaging with startups in a different ways. Like I mentioned earlier, it could be, having small groups that talk to startups and, helping them figure out what the pain points are in different processes. But I think the main thing is just being able to be open-minded and to shift away from traditional ways of doing things.
Okay. Oh, we've got a question there.
So I think that's just to sort of build and clarify that. I think a lot of the time when we talk about pilots, it's the fact that you go and get evidence, as you would for medicine, and you don't get a different part of the country saying, well, we're slightly different here, we need to do all the trials again for medicine, and yet that happens all the time with tech. And I think how do you get that standardisation, that train tracks that Hassan was talking about, where there is an acceptance that you've got the evidence, and your population might be slightly different, your setup might be slightly different, but actually you need to have that ability to say, but we understand that, we can make it work in this, rather than having to go back to square one again and again and again. And it just makes it impossible.
Yeah. Becky, can
I think for me, one of the answers to that is to do with the sharing of evidence, being able to, if you're going to pilot something, write it up, evidence it, show what the impact is and share it, because if we're not doing that, then it's new every time you introduce it. You can't build on anything. Though I have to say that we do know that there are local pressures, so ideally we take the evidence that's been done somewhere else and then we look at the tweaks that we need to make it work locally. We shouldn't have to restart again from the very beginning, but I think that is partly to do with the lack of sharing, isn't it? So I think that's something we're trying really hard to do better, but I think we need to do more of it. But we are certainly, as a health system, we do suffer from pilotitis. It is quite common. So we've probably got time for one more question.
Okay, I was going to be cheeky and combine a few in here, which relates to finance. So the focus on finances, rather cash releasing, cash savings rather than social value. How do we support our corporate colleagues to understand the value of innovation, because often clinicians do get it and they're some of the early adopters, and how can the universities support us around that as well? Just a nice easy one again to finish.
Nick, are you taking that one? Good luck.
I think there's a big role for national decision making on ongoing funding. So I can just talk about this personally. We've had to apply for funds throughout the communication EarSwitch. We've had 3 NIHR grants, and now the next one we applied for we didn't get. So you get something that you've proven within the system that is seen to be valuable, but there isn't that ongoing funding. And we all know with a lot of medtech stuff or any medical innovation, it's a long route to, if you're going to get revenue, a long route to revenue. So if you're just dumped by the funding streams that you had, and you're not actually at a stage that the investors feel that they can actually get a return, you're left in a high and dry. And so that leaves potentially life-saving or life-changing innovations in a very difficult position. And so we've had very similar with the biometrics, but luckily, hopefully we're getting investment. So it is money is obviously difficult to talk about, and we're talking in some ways about public money, and public money is always short, and it's always very competitive. I don't know how many grants we've been through, and we've been very lucky. We've got a lot, but it's probably a tiny proportion of the ones we've gone for. I don't know what the answer is, but I think there almost has to be some areas that are prioritised as being important, and that funding stream is committed to. So if you start in HR at the bottom, if you pass those hurdles, you move into the next stage, a bit like sometimes UKRI I think does that, or SBRI does that. I'm not sure if that answers the question.
I'm not sure there's an ideal answer, but it was a pretty good one, so thank you. I think we're out of time. Thank you so much for listening. The next panel session will be continuing the conversation. We're aiming to look at how do we support those mid-stage innovators that have a little bit of reach, but perhaps how do we help them to go the next step, go beyond those pilots, go beyond those initial adoption journeys. So please do join in for the next one if you can. But I'd like to thank my three great panelists. Thank you so much for your insights. Thank you for coming.